A rhabdomyosarcoma, commonly referred to as RMS, is a type of cancer, specifically a sarcoma, in which the cancer cells are thought to arise from skeletal muscle progenitors. It can also be found attached to muscle tissue, wrapped around intestines, or in any anatomic location. Most occur in areas naturally lacking in skeletal muscle, such as the head, neck, and genitourinary tract. Presentation. Its two most common forms are embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma. In the former, which is more common in younger children, the cancer cells resemble those of a typical 6 to 8 week embryo. In the latter, which is more common in older children and teenagers, they resemble those of a typical 10 to 12 week embryo. Epidemiology. Rhabdomyosarcoma is a relatively rare form of cancer. When RMS does occur, it is most commonly seen in children aged 1 to 5 years old. Less commonly, it can also present in teens aged 15 to 19, and can even develop in adulthood, though this is even more rare. St. Jude Children's Research Hospital reports that childhood rhabdomyosarcoma is the most common soft tissue sarcoma in children. Soft tissue sarcomas make up about 3% of childhood cancers. Diagnosis. The diagnosis of rhabdomyosarcoma is made by a pathologist. He or she will examine a biopsy of the tumor under the microscope and arrive at the diagnosis of rhabdomyosarcoma based on the morphology of the tumor cells and the results of immunohistochemical stains. Diagnosis of rhabdomyosarcoma depends on recognition of differentiation towards skeletal muscle cells. The proteins MyoD1 and myogenin are transcription factor proteins normally found in developing skeletal muscle cells which disappears after the muscle matures and becomes innervated by a nerve. Thus, MyoD1 and myogenin are not usually found in normal skeletal muscle and serve as a useful immunohistochemical marker of rhabdomyosarcoma. Early manifestation can be misdiagnosed as a pseudotumor that is non-responsive to steroid treatment. MRI is the imaging modality of choice for the assessment of the primary adult rhabdomyosarcoma involving most body regions with additional value of diffusion-weighted imaging and whole-body MRI for staging. 3. Classification. Several different histological subtypes of rhabdomyosarcoma exist, each of which has different clinical and pathological characteristics. Prognosis and clinical behavior of the tumor is also partially dependent on histologic subtype. Multiple classification systems have been proposed for subclassifying these tumors. The most recent classification system, the International Classification of Rhabdomyosarcoma, was created by the Intergroup Rhabdomyosarcoma Study. This system attempts to combine elements of the previous systems and correlate these with prognosis based on tumor type. International Classification of Rhabdomyosarcoma. Several additional subtypes of rhabdomyosarcoma exist that do not fit into the international classification scheme. Pleomorphic rhabdomyosarcoma usually occurs in adults rather than children, and, thus, is not included in this system. Sclerosing rhabdomyosarcoma is a rare rhabdomyosarcoma subtype recently characterized by Fulp, al. It is not included in this system. Although botryoid and spindle cell rhabdomyosarcoma are classically considered as subtypes of embryonal rhabdomyosarcoma, they have more favorable clinical behavior and prognosis than classic embryonal rhabdomyosarcoma. Treatment. Treatment for rhabdomyosarcoma consists of chemotherapy, radiation therapy and sometimes surgery. Surgery to remove the tumor may be difficult or impossible depending on the location of the tumor. If there is no evidence of metastasis, surgery combined with chemotherapy and radiation offers the best prognosis. Patients whose tumors have not metastasized usually have a good chance for long-term survival, depending on the subtype of the tumor. St. Jude's Children's Research Hospital reports that more than 70% of children diagnosed with localized rhabdomyosarcoma have long-term survival. Tungsten alloy and RMS. A study has shown a link between RMS and tungsten alloy embedded in muscle. However, the tungsten alloy contains 6% nickel, which is a known carcinogen. A synergistic effect of alloying tungsten with Ni is suggested. Research. Cancer stem cells of rhabdomyosarcoma have been identified and fibroblast growth factor receptor 3 has been suggested as their marker. Preclinical animal studies that try to use conditionally replicating adenoviruses against such cells are in progress. See also, Rhabdomyosarcoma botryoids, childhood rhabdomyosarcoma, references. Sabu, S.S. Krajewski, K.M. Sorkotinsky, K. Howard, S. Jagannathan, J.P. Hornick, J.L. Primaria, N. Imaging features of primary and secondary adult rhabdomyosarcoma. American Journal of Röntgenology 199, W694 W703 doi, 10.2214/AJR. 11.8213. PMIDA 23,169,742. External links. 1. A booklet for parents telling them about rhabdomyosarcoma and what to do if you have a child with this type of cancer. HP, 1956. Rhabdomyosarcomas at Humpath.com. Rhabdomyosarcoma by Leonard Wexler, MD in the Sarcoma Learning Center, Pedonc Resource Center. Information about rhabdomyosarcoma from St. Jude Children's Research Hospital. What is rhabdomyosarcoma? Cancer.org. http www.healthsystem Virginia EduPeds Oncology Rhabdo CFM